The next speaker is Cheryl Phillips, who is the President and CEO of the Special Needs Plan Alliance, and who will be speaking about physician aid in death and long-term care.
Thank you. Thank you all. And so there's going to be a lot of common themes, a little bit more of my background. I'm a fellowship-trained geriatrician, and I spent my clinical years for 20 years in post-acute and long-term care, including as a hospice medical director and also as a chief medical officer of ONLOC, for those of you that follow the PACE program. And so I am now, as mentioned, the CEO of the Special Needs Plan Alliance here in town. But I want to talk my grave concerns about the challenges that we have in post-acute and long-term care. And so I want to go beyond a little bit. When we talk about post-acute and long-term care, those are words that get thrown around, but what do they mean? What are we actually talking about? You notice I didn't include hospice on here. Hospice is critically important, but we've spent the last 2 days talking about it. But I will also point out, and Barbara, you touched on it, very few people have access to an inpatient hospice setting. So when I think about long-term care, I'm thinking about where people live and how they coordinate their lives. So we look at Medicare. If you talk to people on the street, most of them think that Medicare pays for everything. We know it doesn't. And if it's included in long-term care or daily care or personal services, ixnay. Then there's the payment on the custodial long-stay nursing home, which we often think of nursing homes. Assisted living, the majority across the country is still private pay. There's wonderful state exceptions, and Oregon and Washington are exemplars of that, but the majority are still private pay. Home and community-based services that we'll talk a lot about, again, mostly private pay, although Medicaid is a strong presence in this area. And then the whole idea of long-term services and supports. And when we say long-term services and supports, it truly does cover, from a policy perspective, both nursing home, assisted living, et cetera. But functionally, most people think about it as those services that are achieved in the home and community-based settings. And I know you guys know this, but this kind of ties into the story. It's really expensive. The blue, 47%, this is all long-term care, including the little bit of skilled care, which is a 23%, but everything else that is long stay is Medicaid or private, with a touch of some, we think, okay, long-term care insurance is going to pay for it. That's the little brown line. Yeah, not so much. And then there's other VA and government programs. There's a significant burden been touched on, but I want to quantify it. Cognitive impairment, not only frank diagnosis of a dementing illness, but those who have cognitive impairment. We have some data in nursing home and assisted living with estimates up to 70%. We really don't have any good data in those that were requiring long-term services and supports in their home setting in the community. So policy challenges. First of all, long-term services and supports are growing. It's expected to grow another 18% in 2 years. It's already serving more than 2 million people. States are moving quickly to managed LTSS, managed long-term services and supports. That is code for managed Medicaid that covers your long-term services and supports. It may be a portion of your nursing home, it may be all of your nursing home, it may be the home and community-based services. And these are most often funded under waivers. We're not going to get into a health policy, but just to set the stage, if states are moving to block grant payment structures and waivers are an option, and this is a growing population, and states have limited budgets, you do the math, right? So these waivered type programs, the additional services, the home and community-based services, become the very first to be chopped. Now, it's true that states are trying to move people away from custodial nursing home settings, but as long as that is the essential benefit for room and board, nowhere else does Medicaid pay for room and board except in the nursing home and except in some wonderful states like Christmas Tree, Oregon, and Washington, and a few other waiver programs. And again, Medicare is not the payer for this. Then I'm going to add more complexity to the problem. We don't have a workforce. We're challenged. We need to increase our direct care workforce by at least 50%. And this was based on PHI data back in 2010. This ties into immigration challenges. It ties into preparedness challenges. Licensed providers, and we have a wonderful select group here. If you go out in the community, doctors, nurses, therapists, social workers, few are prepared in palliative care or geriatric care. That's just not a skill set that they are presented, they're presented with, they're not presented with in their training. And in most settings, we're talking minimal staffing. When you go to some of the Medicaid nursing homes in many states, they have 1.2, 1.8 hours. Some states have minimum staffing thresholds like California, but very many do not. And so you may have one direct care worker who's dealing with 12, 14, 18 people, and maybe one LPN on the entire unit, and maybe an RN Monday through Friday, 8 to 5. Those are the realities of the workforce in these environments. And then you get to the family and say, well, you can take care of me. Already families are burdened. The estimates are about $450 billion in family caregiver costs. And this doesn't count employment losses in retirement. So I drop out of the work cycle to take care of my loved one. And now I've lost 401k contributions, I've lost salary, I've lost promotions, et cetera. Let alone, most families don't even know how to begin to approach the kind of care that we're looking at with the challenges. I'll just do a very quick anecdote. I remember being in a hospital setting with the privacy curtain that of course is soundproof. And the nurse was explaining to a young woman who was taking an elderly gentleman home who had very bad ulcers on his legs. And she was explaining the care to dress. And the young woman said, oh, but excuse me, I'm not a family member, I'm just a neighbor, I'm picking him up. And the nurse said, that's great, you can teach the wife. And I'm not blaming the nurse, this isn't a nurse issue, this is a system issue where we assume that however we define family caregivers or friends have the expertise, the knowledge, the resources, the emotional capacity to endeavor in this care. So, post-acute care, physician-assisted death in long-term care, the data is virtually non-existent. We've had smatterings of data. I did kind of an anecdote. This was not a data review, but I went to the Long-Term Care Association for Physicians, and the best they could find was 2 in Oregon in nursing homes. So I know you had 9 in 2016 for long-term care, but looking at nursing homes in themselves, California, for instance, doesn't require a place of ingestion. So in general, data is scanty, and I think the underlying concern that we have that is really the overriding policy is the pressures are great, care options are few, families are challenged, cognition is often not well established in this population. So does physician-assisted death really reflect individual autonomy, or is it my best option in a really crappy system of care where my family is burdened? To be rather blunt. And so as we think about our understanding policy, we're starting to understand long-term services and supports a little bit better, but what is this population? What are their drivers? What are their incentives? Is this really a matter of we do not have good access to symptom management and palliative care? Nobody wants to die alone in a nursing home with one attendant for 18 people while you're sitting in your own urine. That's not all nursing homes, please don't, because I love the nursing home settings when they're done well. But when people have that as their vision, the option of saying, I'm going to stop sooner seems very appealing. Is that the right choice? Should we not, in fact, be looking at how to improve palliative care in the long-term care setting? And with that, hey, I got 20 seconds. Woo, thank you.